Yeah, appreciate it. Thank you all for having me. You all actually helped me. I'm a huge Buffalo Bills fan, so this is a tragic weekend for me tomorrow. So I'm going to be putting my mouth into chicken wings and not just looking at the ads. So it's a good distraction for me to be working towards this presentation. So I love managing MDS. So we'll be learning a little bit about, there's a huge armamentarium. I mean, breast cancer docs might laugh, but we have a few drugs in the last few years that are approved. So I just want to talk about how to best use them. I have no relevant disclosures for this presentation. Those of you know me, I have a great passion for advocacy groups. I work with them for several non-profit organizations. What I really like for the audience to learn today from this presentation is a little bit about high-risk clonal cytopenias, how they overlap with low-grade myelodysplastic syndromes, understand the latest developments in the therapeutics of low-grade myelodysplastic syndrome and how they are designed towards improving anemia in different subsets of patients, and a very few, where are we at high-grade myelodysplastic syndromes, just a few updates on that one. So we don't have a long history. Myelodysplastic syndromes has only been recognized by the WHO as a unique entity since 1970s. The first time we know how to manage is when the IPSS group got together and gave us a classification system into low grade and high grade. We've only seen unused since late 90s and approvals with azacitidine, decitabine, which the community of MDS knows how to use for the last many decades now. Lenalidomide was the biggest discovery until the past 2 decades. The biggest change that has happened in the early 2000s is application of next generation sequencing. We try to understand how would all these patients look similar but behave differently by application of NGS and understanding each person's mutational profile. More recently, it's been a little bit exciting to see 4 new drugs approved: luspatercept, oral decitabine, ivosidenib, and imetelstat, 2 of them being just approved last 2 years. So I'm going to give some latest and updates on what the data looks like on these few drugs. Myelodysplastic syndrome is a spectrum. There are several precancerous lesions that have been defined, which the audience should be aware of. What we call is CHIP is just there are several elderly, some younger people too, but mostly in their 7th and 8th decade, walking around with mutations that are frequently seen in blood cancer, but they do not actually have a cancer. They just have normal blood counts and just carry the mutation. These are called it's called the CHIP status. And then a little bit closer to MDS, it's what's called clonal cytopenias, where there's actually a cytopenia, and there is a characteristic mutation or a cytogenetic abnormality that is associated with that cytopenia. This state is called clonal cytopenias. I'm going to delve into this just a tiny bit, and everybody here should know less than 5% blast, persistent pancytopenia, and any clonal abnormality gives us an MDS diagnosis. If your blasts go over 5%, you categorize into higher risk MDS. Low-grade MDS is kind of a colloquial term. So what do we actually mean by low-grade MDS? We have different risk stratification systems that have evolved over time. So IPSS, like I said, was initially designed in 1990s. And anybody that is categorized into low or intermediate 1 risk is what we call the low-grade MDS. If you are using IPSS, everybody should be using the revised IPSS score. And if you have a score less than 3.5, technically the colloquial term of low-grade MDS applies to this patient. If you're using the most advanced staging system, a risk stratification system called IPSSM molecular, if you fall into the first 3 categories called very low, low, or moderately low, you're what is considered as low-grade MDS. It's important because these are the types of patients that are put into clinical trials that are studying drugs that are helping anemia in these patients. So a little bit about CHIP and CCUS. So they're all not one entity within the CHIP status. There are people that fall into high-risk category, those who have higher chance of their mutation turning into an actual cancer. Similarly, clonal cytopenias, where there's no bone marrow dysplasia, only a cytopenia and a clone that is detected, is also classified into 3 different subsets based on new risk calculators. These are called the CHRS for the CYP and the CCRS, and the type of mutation patient has, how their blood counts look, and number of mutations go into this calculator. They're available online. If you come across such a patient, you could use this to actually counsel your patients, how frequently to see them, and so on and so forth. So these risk stratification do not predict overall survival. They actually predict when the myeloid neoplasm, or how much they are at risk for myeloid neoplasm. So there was a study by Moffitt Group that took 2 different data sets, one from the natural history study by the NHLBI, who studied prospectively several a cohort of MDS patients, and a retrospective cohort from Moffitt Cancer Center. And they kind of used the CCRS risk stratification for the clonal cytopenias and compared those patients to a low-grade myelodysplastic syndrome. What you see on this slide is actually progression-free survival. That low-grade MDS and high-risk clonal cytopenias are actually very similar, how much they progress to acute MDS for clonal cytopenias, or AML for low-risk MDS. So the progression-free survival in both the cases looks similar. In the previous slide, I have described it as a unique entity where it has a precancerous lesion. So by like cytopenias, although it looks like a unique entity, when you actually put in the calculator, you actually see the high-risk clonal cytopenia patients are behaving very much like low-grade. Their natural history is similar to a low-grade myelodysplastic syndrome. They also looked at overall survival. If you look at the hazard ratios that are present here, the confidence interval crosses 1 in comparison for high-risk clonal cytopenias in comparison to low-grade myelodysplastic syndrome. So their survival also looks very much like low-grade. So in your clinic, if you're actually seeing a clonal cytopenias patient, you could use some of this data to counsel them or treat them similar, because there are few clinical trials that enroll patients clonal cytopenias. There is retrospective cohorts only available. So this gives you data to manage them like a low-grade MDS should they have symptomatic anemia or so on and so forth. So what does the current treatment algorithm look like in 2024? In the initial slide, I've shown you for several decades for low-grade MDS, we had stimulatory agents and lenalidomide, which continue to be some of the frontline agents. For example, deletion 5q syndrome, if you have isolated anemia. There is some data to use lenalidomide. Earlier you use it, the better it is, based on some Spanish data, and you see the second-line agents that are applicable. Similarly, growth factors what were frequently used. I'm going to talk about COMMANDS data, where luspatercept went from being approved in 2020 in second-line setting to a front-line setting. We have a new agent called imetelstat, a telomerase activity inhibitor. I'm going to give you the most recent update, how it looks in the second-line setting. It continues to be present only in second-line setting, and some other standard of care agents available currently for subsets of low-grade myelodysplastic patients. So here is the COMMANDS trial. This is the most recent update. With the long-term response for any time we talk about low-grade myelodysplastic syndrome, our outcomes are hematological improvements. So we're going to talk about how long patients have remained transfusion independent. Dr. Garcia Manero presented this in December at ASH. So we all know it's a phase 3 open-label randomized control trial where patients were randomized to luspatercept or erythropoietin alpha up to 60,000 units. Luspatercept was escalated from 1 to 1.75, and the primary outcome was actually hematological improvement about approximately 6-month time point. There were some key secondary endpoints, which is what we're going to focus on the most recent update. How long did this transfusion independence last after a year and a half into treatment? That's the focus of the presentation. So we know from initial data, at about 12 weeks, 80% of the patients, this is all comers, not just ring sideroblastic myelodysplastic syndrome, where we know the response rate. This population was enriched for ring sideroblastic, all comers at 12-week time point. So within 3 months, approximately 80% of them had hematological improvement compared to 55% on erythropoietin alpha. At 1 year, these numbers look at approximately 45% and 25%, and about 1/3 of the patient at a year and a half into treatment remained transfusion independent compared to only about 10% so twice as many people remain transfusion independent. So One of the things or criticism of this data is actually the ring sideroblasts were actually enriched. The question that we wanted to answer is if you did not have ring sideroblasts, should we still use this as a frontline data? So people are really interested in subset analysis. So some subset analysis was shown to us with if you were a low transfusion requiring patient versus a high transfusion requiring patients. These show that across all the subsets that luspatercept were really helpful, but especially if you have a low serum erythropoietin from the get-go, you have a higher chance of responding to luspatercept, but across all subsets, luspatercept was superior to erythropoietin alpha. Similarly, in ring sideroblast negative myelodysplastic syndromes as well, you see that it is actually more responses compared to, one can question the relative 25% versus 15%, is that 10% truly significant? But the subset analysis, even on long-term follow-up, shows that luspatercept continues to be a winner. The numbers may not be as impressive compared to erythropoietin alpha. There is a current clinical trial ongoing, if you do have access to or anybody is requesting, called Elements MDS trial. I don't believe it's available within Memphis area. It is looking for non-transfusion dependent, non-del5Q, non-ring sideroblastic patients that have hemoglobin anywhere from 9 to 10 to people are slowly trying to buy this ring sideroblast negative. Luspatercept is still better than current practice. My practice is to do erythropoietin and ring sideroblast if their serum EPO is less than 200. But I think we are heading into a direction to gather more data prospectively in this. At least the commands data gives you some data. Should you consider it, it's a personal discussion if they should, a patient should be interested in luspatercept as a frontline agent, even though they're ring sideroblast negative. This provides some support for such a practice. There's always been, across all myeloid disorders, myelofibrosis, MDS, there's always been a push to not let a person become transfusion dependent because the disease process has moved along in terms of information. Is there an advantage to actually give earlier ESAs? So our friends from France have actually tried to answer this question in the GFM EPO PRETAR trial. They randomized 1-to-1 patients who are not transfusion dependent yet. So they randomized patients between 9 and 10 hemoglobin and those who are between 8 and 9 grams of hemoglobin and tried to understand the primary endpoint was time to RBC transfusion dependence. So it was a negative trial. The time to transfusion dependence, the primary endpoint wasn't met. It was really the same in both the arms, but what we actually learned is the patients who did start erythropoietin earlier in their disease course actually had a higher response. Their hemoglobins were higher, and the number of patients that responded were relatively higher. And this reflects if you should have a patient who complains of fatigue at 10, and you did consider EPO, we see this commonly, so this reflects some of our practice patterns and wasn't shocking for us to see. Yes, if they started treatment earlier, they remained on treatment for a longer time. That was no surprise. What was not so impressive is the quality of life. Even though number of patients responded, the quality of life indicators, which is pretty which one would expect it to be different, they were similar in both the arms. So it remains a debate whether to initiate ESA earlier than becoming transfusion independence. If you do such a thing, this data does support it, that people do that. It's a case-by-case discussion. You really do not want a cardiac patient to slide below 8 grams of hemoglobin. You just have number of hemoglobin stay higher for a longer time. Combining ESAs and luspatercept. So people are trying to really understand how to best combine these agents. Should we use one after the other? There are lots of outstanding questions. Again, our European colleagues have presented very initial data showing that the combination is basically safe. So combining ESA and luspatercept for patients who do not have ring sideroblasts again, what should we do with them? So it's a phase 1-2 study. They're trying to understand the safety data. We shouldn't be really talking about clinical efficacy in an early phase. There is a phase 2 portion of this ongoing. So the study talks about the first 24 patients that were enrolled into different dose levels of luspatercept, and there's a continuous dose escalation with these data. Every assessment happens at each dose escalation for safety and efficacy. The conclusion from this Cambola trial is that luspatercept of 1.75 milligrams per kilogram given every 3 weeks, which is what we do standardly, and an EPO dose of 60,000 units there is a clinical efficacy actually seen in about 1/3 of the patient and was relatively well tolerated. So this was identified as the phase 2 dose, and the trial continues to enroll in Europe. So effect of switching to effect of prior treatments on activity of imetelstat. Imetelstat, as we know from the IMerge data, we have nothing before chemotherapy when people failed luspatercept or erythropoietin. The agent that's now available is imetelstat that is frequently used in second-line settings. So how did these people do? Did prior treatment with ESAs or lenalidomide or any of this, did they actually have an effect on the treatment? I think this is not such an updated slide, so you have to trust me on my memory for this. So about 10% of the patients were previously treated with ESAs, and 40% of them had a response. So it is similar. If you have prior ESA, you still have 40% response, which is the primary outcome. Lenalidomide, 12% of the cohort had prior len therapy. About a quarter of the patients had response, so not quite the 40% we saw. Luspatercept, about 28% was, so 40% for the overall cohort, but if you had received luspatercept before, it's about 1/3 of the patient received a response, hematological improvement. If you did actually have prior HMA therapy for alleviating anemia, these are the patients who had the least response. They had about 19% response. In the clinical trial, if you remember, it is placebo versus imetelstat. Even on the placebo arm, people had 19% response. So should we really, I think what it tells you is that using imetelstat post-HMA is not that clinically efficacious. Perhaps we have to push chemotherapy back to a third-line treatment and probably use imetelstat preferably as a second-line treatment. This is, again, different subsets of imetelstat. We all know that luspatercept in the subset analysis I've shown you earlier, the confidence interval was wider for high transfusion requiring patients. If you have a high transfusion requiring patients, you actually see that 40% holds true for low transfusion requiring total number of transfusions versus high transfusion requiring patients. All right, switching gears, that was low-grade MDS patients. There is not a lot happening in high-grade myelodysplastic, so excess blasts now. So we're aiming to decrease blasts. Everybody knows if you're transplant eligible, you induce and take to transplant. People commonly use HMA monotherapy. If you do currently have a transplant eligible patient, it's a non-FDA indication. We at our institution frequently use venetoclax in these patients with the 10 to 20% blasts, the cusp of AML and MDS type of patients. We do not have the Verona trial, which is the most awaited trial with venetoclax as frontline therapy for high-risk MDS patients. The study is still awaiting reaching all the events for analysis. People are afraid the control arm is receiving a lot of ven off-label, as we all do. But we're hoping it's a positive trial, and we'll actually finally have ven as an approved drug for MDS, but that data is still awaited. This is the phase 1/2 trial. We have a little bit longer-term follow-up that has been updated this past ASH. And as we all in clinic, as we are using, we see a lot of patients, there was nothing for these patients when I was a baby doctor. The HMA failed, you had a few months, and then they became friends with hospice and palliative care. It is a game changer that we are actually now talking about an effective treatment in second-line treatment. Whether it's approved for frontline, we don't know. Verona is waiting, but 80% overall response rate and median time to respond, very similar to AML, about 2.5 months. When you do respond, you actually stay on it for about 16 months. So the duration of response is pretty durable. The idea is if you're transplant eligible, you're supposed to proceed to transplant. Survival, just as a comparison, previously HMA failures was median survival is 6 months. The fact that we are talking about 50% of the patients alive at 2 years is is a great credit to venetoclax and what it is doing to these MDS patients. Everybody's dreaded diagnosis is TP53 mutant AML and MDS. There is clearly nothing that is a game changer, but we are learning how to best use what's available to us. There are several clinical trials that I point out in my summary slide, but this study is an oral decitabine, the Ascertain study that showed the oral decitabine was non-inferior to other HMA agents that we use. So MD Anderson group went back and looked at their TP53 mutant cohort and divided them into wild type, single hit, and multi-hit. And they compared their cohort to the patients that actually were treated on oral decitabine and saw how they did. So about 47 patients on each of these subsets had a propensity matched analysis. So they look similar in age, co-mutational status, and all the other characteristics mentioned there. What they saw is the total number, the overall survival of the patients on oral decitabine with TP53 mutant was higher, with a median survival of 13.1 months compared to 8 months. This is TP53 mutant MDS, so it's like stage 4 pancreatic. Any few weeks or months of difference is a big deal for us. Although this is a retrospective study, makes one think, should I be using oral decitabine as a preferred agent for my TP53 mutant patients as compared to IV decitabine or oral azacitidine? So, treatment for CCUS, there is nothing out there. You can treat them as low-grade MDS, but there are ongoing clinical trials using canakinumab and oral azacitidine and so on forth. First-line treatment, I mentioned earlier, if there is a non-transfusion ring sideroblast negative patient and they are interested, Elements MDS is a clinical trial that's currently accruing. There are many other exciting, the data has been published, but a very early phase to be discussing in detail about an anti-inflammatory NLRP3 inhibitor, IRAK4 inhibitor, and IDH, which is currently approved. There was extended data on it in the first line. These are some of the trials that are currently accruing and data that drugs that we need to stay tuned to in future. I think that's my slides. Thank you very much. Appreciate it.
Thank you again.